Hello, let's talk about the parathyroid glands and calcium homeostasis. This SDL begins by discussing what the normal parathyroid looks like. They're really not going to ask you about the different types of cells in the parathyroid. What they do want to ask you about is what parathyroid hormone does to calcium systemically. Normally, PTH and calcium are directly proportionate. When PTH goes up, calcium goes up. When PTH goes down, calcium goes down. So let's talk about where PTH acts. First and foremost, parathyroid hormone is going to act on the kidneys. It will increase the hydroxylation of pre-vitamin D to its active form, calcitriol, 1,25-dihydroxyvitamin D. It upregulates the enzyme that does that, and that enzyme is expressed in the kidneys. So what does vitamin D do? It upregulates calcium reabsorption from the gut, and it also builds bone up. So if you don't have any vitamin D, then you're not pulling calcium in from your food, and you're also not building bone. You will be breaking it down because you'll get a little hypocalcemic. PTH does something else in the kidneys. It acts on the tubules to manipulate ion reabsorption. So phosphate and calcium typically exist in a inverse relationship in the bloodstream, meaning when calcium goes up, phosphate drops, and vice versa. When calcium is low, phosphate's a bit higher in the blood. And the reason for that is because calcium has a positive 2 charge and phosphate has a negative 2 charge, amongst other things, I'm sure. So phosphate is reabsorbed potentially in the proximal convoluted tubule, and it's got a specific organic anion transporter. And PTH, when present, will block the expression of that transporter on the apical surface of proximal convoluted tubule epithelial cells, and so it will block phosphate reabsorption. Now, PTH will do the opposite down at the distal convoluted tubule. It will upregulate the expression of calcium transporters, and specifically a calcium sodium transport. I can't remember if that's the apical or basolateral side, but the point is you pull more calcium in from the distal convoluted tubule when PTH is in the blood. In the GI tract, PTH does something similar to vitamin D. It makes it easier to pull calcium in from your food. And in the bones, PTH promotes reabsorption of calcium from bones. So that's bone remodeling is another way to say that. It stimulates osteoclastic activity to put calcium into the bloodstream. So when you need calcium in the blood, PTH is who you call. Hypoparathyroidism is low PTH leading to low calcium. The most common cause of this is going to be damage to the parathyroid glands from surgery. Now, a lot of different procedures have you digging up in that region. The parathyroid glands are right behind the thyroid glands. They're on the posterior aspect of it. And so that's right around the carotid and the vagus and the jugular. And most common surgery leading to parathyroid damage is going to be a total thyroidectomy, which we know is a treatment for various cancers, things like Graves' disease. So if you nick the parathyroid glands, then you might see hypoparathyroidism either immediately, if you just mess that dude up, or like years down the road if you just kind of tickle it. There's also hungry bone syndrome, another acquired cause of hypoparathyroidism. And hungry bone syndrome means that your bones are going to be pulling a lot of calcium out of the blood. They're hungry, they want to eat. That's kind of my visualization of it. So when do you get hungry bone syndrome? You get it whenever a patient has had hyperparathyroidism, and then they get their parathyroid glands out, and because their body's accustomed to a whole lot of PTH, well, PTH drops off a cliff. And so remember, PTH encourages bone remodeling, osteoclastic activity. So if you don't have any PTH all of a sudden, what that means is you are going to be building bones. You're going to be like Minecraft up in those bones. You're going to be Fortnite up in there. You're going to be building so much bone. And what that's going to do is pull calcium from the blood. So you're going to get a transient hypocalcemia. And so the treatment for this is to keep a patient infused with some sort of calcium drip and time dependent. And they're eventually going to recover their own calcium homeostasis naturally, but you do have to treat them with calcium until that occurs. Moving on from acquired causes, there's also an autoimmune hypoparathyroidism in which T cells are attacking the parathyroid gland. It's an autoimmunity. And so this is going to occur whenever a patient has mutations in the AIRE autoimmune regulator gene. And this can give you what's known as APS1, autoimmune polyglandular polyendocrine syndrome type 1. And another word for it is going to be APOSED, autoimmune polyendocrinopathy candidiasis ectodermal dystrophy. So know both those names, be able to spot them, understand it's the AIRE gene. What's happening here is a defect in negative selection. So understand T cells mature in the thymus, and part of that process of maturation is medullary thymic epithelial cells presenting various proteins to T cells and then gauging the affinity of those T cells to bind to those proteins on major histocompatibility complex molecules. And so if a T cell binds too tightly to the side of an MTEC and it really, really loves that self antigen, that's a signal for us to get that T cell out of here. We don't want him in the bloodstream because he's just going to pop off against that antigen if we let him go. So that T cell will commit a mediated apoptosis and it will be no more. And then that's how we protect ourselves from autoimmunity normally. Now, if there's a defect in this process, you're going to have a lot of T cells running around in the bloodstream that are very, very reactive against self-antigens. And that's how you get this disease. So how does it present? Well, first you get Candida. That's a fungal species, likes to give you oral candidiasis, vaginal, esophageal, might just be a skin infection, a lot of different ways to get Candida. But anytime you see Candida, you can about bank on it that the patient is immunocompromised somehow. Other risk factors are diabetes and oral contraceptives, but mostly patients that get Candida are immunocompromised. You will also see hypoparathyroidism presenting as hypocalcemia because the autoimmunity is directed against the parathyroid glands. And finally, you see Addison's disease in this APS1 syndrome. And what's Addison's disease? Well, that's when the adrenal glands have typically an autoimmune response against them. It can be due to a couple different things such as cancers or tuberculosis, but by far the most common cause of Addison's disease or primary adrenal insufficiency is autoimmunity. There's also DeGeorge syndrome, which is colloquially known as thymic aplasia. So the thymus just fails to form. So you don't have a lot of T cells to start with, but just for free, you also get parathyroid aplasia. This is a bad disease, and it's due to the failure of the third and fourth pharyngeal pouches to form properly. So alongside the parathyroid and thymus aplasia, you will see cyanotic heart defects such as truncus arteriosus and tetralogy of Fallot. There's also a typical facies of DeGeorge syndrome. I won't go into that here. Then we have a couple of way less common diseases. I don't think that these are imperative for you to really know for the exam, so skip ahead if you feel like it. One is because of an improper response to calcium, blood calcium levels by particular sensing cells in the parathyroids and in the kidneys. So recall in polycystic kidney disease, there's a mutation that plays with this cilia. And so if you don't have the cilia, remember that the bending of certain cilia and certain tubular cells of the kidney, the mechanical bending of those cilia opens up calcium channels on the surface of these cells, and that lets us know how much calcium we're getting. And so it tells the kidneys how much calcium they ought to be reabsorbing. So if those aren't functioning properly, you don't sense calcium. And then in polycystic kidney disease, well, those cells just blow up. But here it's kind of something similar in that it's the calcium channel that's not working. So it's a calcium sensing receptor, literally. And so what's going to happen here is it's going to be tough to maintain a normal serum calcium concentration. And these patients will be losing a lot of calcium into their urine as a result, because you're just kind of not seeing the full picture of all the calcium in the blood. So you think you're hypocalcemic because the receptor's bad. And so or maybe I suppose you think you're hypercalcemic and so you let off a lot of calcium in the urine. But point being, you're peeing out a lot of calcium. How does this present? Stones. Calcium's a major component of a lot of different kidney stones. Now, something of the same vein is going on in pseudo-hypoparathyroidism, but in this pathology, it's an end organ unresponsiveness to parathyroid hormone rather than to calcium. So this is due to a loss of function in the GNAS1 G protein alpha subunit 1 gene, which is the same thing that's mutated in McCune-Albright syndrome, polyostotic fibrous hyperplasia, right? And well, here's Albright again, go figure. Probably the same Albright as is in McCune-Albright. You can get Albright hereditary osteodystrophy, in which patients have a characteristic really short fourth finger, and subcutaneous calcifications. They're very hypercalcemic because if tissues aren't responsive to PTH, you're going to have to make more PTH. And so then you got more PTH, got more calcium into the day, and so you get dystrophic calcification. Or would that be, I think that'd be metastatic calcification actually, not associated with pathology, just due to high blood calcium. So that's our metastatic calcification. So if patients got low PTH and low calcium, how do they present? What they are going to give you on boards is tetany, which means it's a muscle cramp essentially, and it's hyperreflexivity as well, which means that you just brush them with a feather and they contract their muscle like that. So you got two signs you can look for. Chvostek sign is the most easiest and most common. That means you're going to tap right here over the facial nerve, and the side of the face that you tap when they're hypocalcemic is going to go like, you know, like it's Billy Idol or something, like, you know. So there's also Trousseau sign, in which case you put a blood pressure cuff on, you blow it up. So you're compressing one arm, and then what's going to happen is the patient's hand, when you check back a few minutes later, the patient's hand is going to be stuck like this. It's going to be contracted. So the flexors of their forearm are going to be contracted, and they're contracted because of the low blood calcium. Now, on an EKG with low calcium, you're going to see a prolongation of the QT interval, because think about the action potential in the heart. You've got 4 phases, and phase 2 here is going to be a plateau phase. And during the plateau phase, you have potassium and calcium channels open. And so during the plateau phase, the cell has a membrane potential of, it's depolarized, right? And so it's like roughly 0. And so what's going to happen is you've got calcium and potassium channels open, and calcium goes in, and then eventually you're going to reach the point where you can push nothing but potassium out, and that's going to repolarize the cell back down to -55 or -90, depending on the tissue that you're in. So if you don't have a lot of calcium, then it's going to take a long time for this plateau phase to culminate, because you need a certain amount of calcium to go out. And that's it. The amount of calcium that is going to leave the cell is going to be more when you have a hypocalcemia. I think I explained that right. I probably made a couple of errors there, but look it up on your own, please. And finally, seizures can occur in hypocalcemia, big bad ion imbalance, and the brain really doesn't like that. So let's check out tetany and talk about that a little bit further. Now, calcium typically floats around in the blood bound to albumin, and hydrogens also float around bound to albumin. So if you have an acidosis, you're going to have less calcium bound to albumin because it competes with hydrogen for binding spots, and more free calcium. So depending on if you're acidotic or alkalemic, you might see symptoms of hyper or hypocalcemia respectively. Now, in alkalosis, you have a high pH. That means you have a low blood concentration of protons. So more free calcium is going to bind albumin. And so you're going to have a hypocalcemia. Now, this is somewhat of a clinical problem, because whenever you do a blood calcium panel, the calcium that's bound to albumin gets counted in that. And that's what you get on your metabolic panel. You get the bound calcium plus the free calcium, which is also called the ionized calcium. So when you get that metabolic panel back and you're just like, oh, well, calcium's fine, it can't be a calcium problem. Well, consider that maybe the ionized calcium is abnormal, you know, so try to order that if you're really suspicious of a calcium problem. So here's a graph showing you that as pH goes up, the proportion of calcium that is bound to albumin rises, and the proportion of ionized calcium drops. That's free calcium. And again, it's because it competes with protons for binding sites on aspartic acid and glutamic acid, which carry a negative charge. And so they can bind cations like hydrogen and calcium. And so if it's unoccupied because a proton's not going to fill it up, well, then calcium will sure do that. And so in alkalosis, there's less protons, and so more calcium binds albumin. So there's less free calcium, and this is going to give you a tetany. And of course, if you have a hypocalcemia, I mean, you're getting tetany no matter what. So what's tetany? Well, tetany means that it's easier to form action potentials. And so that's why you've got spasmodic muscles, spasmatic, I suppose. Your muscles fire just at a whim, you know. It's really, really easy. You get these jerky contractions and they stay contracted. And the reason for that is because the membrane potential in a hypocalcemic cell over here on the right side of the screen is lower than the membrane potential of a cell that has a normal level of calcium on the outside. So calcium is a cation, and so that contributes to a positive charge in the extracellular fluid, and that raises the voltage of the extracellular fluid. So if you have less calcium and all other ion concentrations are the same, then your extracellular fluid will have a lower voltage than if you had a normal calcium. And so that lower voltage means you have a less membrane potential. And that lesser membrane potential means it's easier to depolarize a neuron and send an action potential down it. And so when that happens to the neurons that go to your skeletal muscles, they jerk. So that's tetany. Here is a great graph. I would say learn this, memorize it, understand. PTH on the y-axis, calcium on the x-axis, and we got this box in the middle that's representing the normal range of serum calcium. And then on the top and bottom of the box, it's representing the normal range of serum parathyroid hormone. So obviously, if something is going to be out of the normal range, then it'll be elevated or decreased on the axis of the graph. So I bring this up to say that hypoparathyroidism is always the left lower quadrant of this graph because PTH and calcium will both be down, and calcium does what PTH tells it to. So a hyperparathyroidism, PTH is up, and so calcium is accordingly up. Now, if you get a patient and their blood PTH is up, but their calcium is down, you know that that's a secondary hyperparathyroidism. Maybe they have a vitamin D deficiency. Maybe they've got kidney failure and they can't hold on to the calcium even though parathyroid hormone is up. And then also in this right lower quadrant, what if calcium is up and parathyroid hormone is down? Well, we know something might be producing calcium within the body, and calcium is going to feed back and inhibit PTH eventually, you know, and so maybe you've just got way too much calcium on your hands. And so that could be the hypercalcemia of malignancy. Maybe you got a cancer doing that. And it could also be in the setting of vitamin D toxicity, even though that's rare. Some people just get way too much vitamin D. Helpful graph to know. Here's a separate look at it. That's how you want to be thinking about it. So that's about wrapped up our discussion on hypoparathyroidism, left lower quadrant of that graph there. Easy to remember. Now let's talk about primary hyperparathyroidism. So primary means it's the parathyroid glands themselves, which are dysfunctional, overactive in this case. And secondary would mean that you're getting PTH from somewhere else in the body. Maybe you got like a PTHRP, paraneoplastic syndrome, for example. So in primary hyperparathyroidism, PTH is up, so calcium is up. Other causes of secondary, well, we'll talk about secondary, but I don't need to say that right now. Primary hyperparathyroidism, it's cancer most of the time. It's cancer 8 times out of 10, and the other 2, it's going to be hyperplasia, which is pre-cancer. So anytime you got a primary hyperparathyroidism, you're thinking cancer of the parathyroids. What's the risk factor? Radiation. What does it look like? Doesn't really matter because there's not a great diversity of cancers here, and you're going to know that it's the parathyroid that's messed up, you know. So we got an adenoma and a carcinoma. Adenoma is benign and non-invasive, thus it's encapsulated. We've got a carcinoma, which really does not look that different from adenomas histologically, so we don't care about what it looks like here. You might see some broad fibrous bands. I would love for her to throw that in the question, you know. That'd be a real mean thing to do. And of course, if it's invasive, outside of its encapsulated structure. Or if you encounter a metastasis, then it's a carcinoma by default. And then there's parathyroid hyperplasia, which this paragraph is much ado about nothing. The question will be about the genetics. So two different genes you could have mutated in an adenoma, and then there's only one gene you see mutated in a carcinoma. So if it's a benign cancer, you can put your money on the CCND1 gene, and that's an oncogene, so there's a gain of function mutation in that gene. It's also called PRAD1, parathyroid adenoma 1 gene, and it is encoding cyclin D1. There's also the MEN1 gene, which encodes menin involved in multiple endocrine neoplasia type 1. Parathyroid adenomas are characteristic of that syndrome. We'll talk about it later in this SDL. The RET oncogene is really not associated with parathyroid cancer. You might see hyperplasia of the parathyroids in the setting of the RET gene, but that is very, very, very rare. And you see parathyroid stuff, you're thinking like MEN1, in all honesty. Then finally, if you have a malignant cancer of the parathyroids, it'll be your HRPT2 gene. 77% of sporadic parathyroid carcinomas, so a big strong correlation there. The protein's name is parafibromin, and it is a tumor suppressor gene. So patients with hyperparathyroidism, hypoparathyroidism, we said the big sign was going to be spastic contraction of muscles called tetany. So hyperparathyroidism, you're not really going to see any musculoskeletal signs. If you do, their DTRs might be a little bit slower than normal because you're going to have a greater extracellular voltage. So there will be a greater membrane potential and thus more difficult to mount an action potential down a neuron. Some telling symptoms of hypercalcemia secondary to hyperparathyroidism are going to be kidney stones, absolutely, nephrolithiasis, and they might even be recurrent if it takes you a while to diagnose and work this patient up. EKG, you're going to see shortening of the QT interval due to that plateau phase becoming more brief. Remember, the plateau phase is when calcium channels are open. And so when there's a lot of calcium, then that stage wraps up quickly. And so you got a shorter QT interval there, shorter action potential. Vascular and valvular calcification, do not underrate this. This is a bad problem. Calcification of the aortic valve is a bad disease. And then peripheral vascular calcifications, that's going to be, oh Lord, it starts with an M. I can't remember it. It's related to diabetes as well. Munkeberg calcific sclerosis, something like that, And finally, big GI symptom of constipation. Why? Because your GI is nothing but smooth muscle. And a bunch of calcium thrown into muscle means that, well, calcium is what keeps actin bound to myosin, because it's going to activate that troponin and move it aside so that you can get cross-linking of your actin-myosin bridges. So you got a lot of calcium. That means your cell's got to work harder to sequester calcium inside its endoplasmic reticulum. And if you got a lot of free calcium, even in between contractions, then the cell's just going to stay contracted. So imagine that your gut is a tube, right? So it's got a circumference and a diameter, right? As a tube does, a cylinder. And so if it's contracted, it's clamped down, right? And so if it's clamped down because it stays contracted persistently, are you getting any food through there? No, you're not, especially not if you go eat a real big meal, food is going to hit that and it's going to say, oh, so there's the constipation. Lastly, when you have primary hyperparathyroidism, you might see this thing called osteitis fibrosis cystica. So remember that PTH upregulates osteoclastic activity to pull calcium out of the bone and put it into the bloodstream. So if you got too much osteoclast, you're just going to be eating holes in your bone. And that's essentially what this OFC condition is. It's got a very characteristic brown tumor that pops up, and the brown discoloration is due to hemosiderin. Lab studies, remember this graph that we're looking at. Hyperparathyroidism is going to be in our right upper quadrant over here with high calcium and high PTH. Because calcium's high, phosphate goes low. That's pretty bad because you need phosphate for adenosine triphosphate. You need 3 of them actually. And so you do use a lot of phosphate on a regular basis. So that hypophosphatemia leads to really quick lethargy and fatigue. Hypercalciuria, there's so much calcium, you got to excrete it somehow. And most importantly, elevated PTH. And the SDL says that is at the core of the diagnosis because PTH levels will tell you if this is a primary or secondary hyperparathyroidism. Here's some imaging. Look at these radiolucent areas of the skull here that are less dense than after treatment. They're less dense because of the osteoclast activity in this photo on the left. Here on the right is osteitis fibrosis cystica. You can tell why it's called cystica. These are cyst-like spaces in long bones. This is the tibia here. Is this the right or the left tibia? Left tibia, yes, good job. Fibula's on the outside. So again, if you were to look at it histologically, you'd see big color brown tumors because of hemosiderin. And what do we got on the left here? Subperiosteal reabsorption. That is buzzword city right there. And what they're really pointing at is how it's faded along the perimeter of the bone, just right there, and also right here. So the periosteum is the skin of the bone, kind of like the perineurium on a nerve, or the perimysium of a muscle. So peri just means it's the layer around it. So the periosteum, right underneath that is where the bone gets pulled from first. That's what that photo on the left is telling you. Here's a technetium scan. We do technetium scans for a lot of things. Meckel's diverticulum is the first thing that comes to my mind. And so there's a particular isotope of an ion that we can, or a molecule we can throw in the bloodstream, and the parathyroid takes it up, and we check back a couple hours later, and it's hot if there's hyperparathyroidism. So now we got secondary hyperparathyroidism. That means that you got a lot of PTH due to a cause other than the parathyroid glands having some hyperactivity. So primary hyperparathyroidism is the parathyroid cancer, essentially. Secondary is going to be due to a little bit bigger differential. Renal failure is up there because you're not going to be reabsorbing any calcium. So calcium stays persistently low. So PTH stays persistently high to always be pulling it from bones. Vitamin D deficiency as well, because vitamin D is going to raise your blood calcium. So if you don't have vitamin D, you don't absorb calcium from the gut. You don't pull it from your bones. You lose it. So you raise PTH due to the hypocalcemia there. And then finally, bariatric surgery, something like a Roux-en-Y bypass, in which a large part of the small intestine is excised or rerouted. Then, well, where does most reabsorption of foods take place? The proximal small intestine, the duodenum into the jejunum. So you have some sort of bypass surgery. There's just less overall absorption of many things, calcium being one. So that's a cause of hypocalcemia that can lead to a secondary hyperparathyroidism. That's really all I got to know about it. You can sure get that osteitis fibrosis cystica with secondary PTHism as well as primary, because the main cause of that bone remodeling is parathyroid hormone, and that's high in both cases. But what you really want to understand is that a secondary hyperparathyroidism is going to be in the top right quadrant of this graph that you should be familiar with by the time you take the exam, in which PTH is high in the face of a low serum calcium. So that would be secondary hyperparathyroidism. Tertiary, you almost never see this. It's almost always after a kidney transplant. So the story here is that the kidneys fail, so you've got a very low calcium because not only can you not reabsorb it, you also can't conjugate vitamin D. So you've just got a ton of parathyroid hormone. And so you get a kidney transplant, and your parathyroid hormone levels should normalize as your kidneys retain or regain their function. But in this setting, the parathyroid hormones have been working so hard that they're like, yo, I've got these gains, man, I want that clout. And so they become autonomous because they're not going to stop making PTH. That's all that they're used to at this point in life. So you get this autonomous nodule of chief cells, which are the functional cells of the parathyroid gland, and they continue to give you a large PTH level in the setting of functional kidneys, and so calcium will eventually go up too, but due to the setting of kidney transplantation, you're going to know this when you see it. Finally, multiple endocrine neoplasia syndromes. You guys can study the most of these on your own. First Aid's got a good look at it. And there's really not much I can tell you because this is just the match game. You know, this is the vocabulary test. You either know it or you don't. You've got 3Ps, 2P, 1P going from type 1 to type 2A to type 2B. And all of these are autosomal dominant syndrome, endocrine. Okay, so the endocrine system, neoplasia, cancer. So you just get cancers in multiple endocrine organs. That's all that these things are. So type 1, you got 3Ps, parathyroid cancers, pituitary cancers, pancreatic cancers. Now, the pituitary cancer is typically going to be a prolactinoma. That's the most common. And then a growth hormonoma is going to be the second most common. And that's just because the most common cell type in the pituitary is the lactotroph. Pancreatically speaking, the gastronoma is the most common neuroendocrine tumor of the pancreas in the setting of MIN1. So remember, the gene is MIN1, the protein is menin. And what's a gastronoma? It's going to make a lot of gastrin. What does gastrin do? Goes to your parietal cells of the stomach and gets them to secrete hydrochloric acid. And so you're going to have a hyperacidic stomach with a very low pH. And so symptoms of heartburn, maybe GERD, maybe peptic ulcer disease. And fun fact, about 90% of these gastronomas are located in the duodenum rather than in the pancreas. That's the most common. Second most common is the insulinoma, which is going to present with a very low blood sugar after a period of fasting that improves upon administration of glucose. And also when we say low, we're saying like 50 mgs of glucose per deciliter or lower. So we call that Whipple's triad. Two big associations. We also have an SDL on pancreatic neuroendocrine tumors. So there's the connection there. And then finally, the primary hyperparathyroidism that is going to result from the M1 condition, frequently due to hyperplasia of the parathyroid glands, but that can turn quickly into an adenoma, a benign tumor. And that portion of the parathyroid will just be making PTH all day long. So you will have a high blood calcium accordingly, and you'll see all the symptoms of a high blood calcium, including constipation, shortened QT interval, hypercalciuria. Interesting one here that I didn't catch earlier in the SDL, polydipsia and polyuria. So what's that? That means that you're peeing a lot and you're very thirsty, you're drinking a lot. So why? Well, calcium in the tubule of the kidney actually inhibits the action of antidiuretic hormone. So antidiuretic hormone, pulls free water back in from the urine into the bloodstream. So if you have a lot of ADH, then you have a small amount of highly concentrated urine. But if you don't have any ADH, then you've got a large amount of very dilute urine with an osmolarity like 30. So if calcium inhibits ADH, that's more urine volume because you're losing free water. That's MIN1. MIN2A versus MIN2B. 2A's got 2Ps, pheochromocytoma and parathyroid problem. And then MIN2B, you really don't see parathyroid disease. What you really see there is just the pheochromocytoma and medullary thyroid carcinoma. Now, because both 2A and 2B involve the RET oncogene, there is a 100% presentation rate of medullary thyroid carcinoma if you have inherited this autosomal dominant multiple endocrine neoplasia type 2, A or B. That means if we know you have the disease, we can say with a lot of confidence, you will get medullary thyroid carcinoma if we do not take your thyroid out. So these patients, when they're 20 or 30, early on in adulthood, they will get a thyroidectomy to protect them against the risk of developing a medullary thyroid carcinoma. So what does the medullary thyroid cancer look like? Well, amyloid, remember that. Calcitonin, remember that. There we go. Easy. So RET is an oncogene. It's mutated. Cells just grow and proliferate without needing growth factors. 2A and 2B have RET mutations. 2A and 2B both have pheochromocytomas. We have another SDL on that. And what is going to help you tell 2B apart, besides the lack of calcium imbalances, is going to be a characteristic marfanoid habitus in 100% of cases. So marfanoid means they don't have marfans. It's just kind of like marfans. And so when we say marfanoid, we mean that their skull's a little elongated top to bottom. They've got a high arched hard palate. We mean that they have pectus excavatum, which is going to be a little bit of a sunken chest. Bilateral pes cavus is also common in scoliosis, kyphosis, spinal column, bendy irregularities. There's a way better way to say that, but those are all part of the Marfan clinical picture. Also, patients are going to have mucosal neuromas, which present as bumps on the oral mucosa, so the lips and the tongue and the inside of the cheeks, but possibly even the GI mucosa if you were to do an EGD on these patients. That's about all this SDL's got. Thanks very much.